So there's two main psychotic symptoms, delusions and hallucinations. So delusions are the beliefs part. So they're fixed false beliefs. So you can't change them by arguing a person out of them or convincing them otherwise. And in fact, people with true delusions will shift their perspectives and shift what's going on to keep those fixed beliefs true in their minds. It doesn't matter if it's true to anyone else, it just needs to be true to them. And they're false. I mean, like I said, the gentleman who thought the bikers were after him, that's not a delusion because they were actually after him. And so it isn't a false belief. The second qualifier there, not in keeping with societal, cultural, and group norms, is a really important one because we don't consider things, cultural beliefs that are widely held across the region to be delusional, even if they are not necessarily true, or a lot of people from another culture don't believe them. And part of the reason this sort of thing is in here is to not pathologize things like a religion, where a belief might not be demonstratively true, but it's not something that is due to a distortion or a strange thoughts of the mind. It's part of the cultural norm. Then the flip side of that is the sensory problems with hallucinations. So these are sensory experiences that occur in the absence of an actual stimulus. So seeing something that's not there, hearing something when there's no one there, there's nothing there to make the sound. And they can occur in any sense. The order that I presented them there is pretty reasonable as an indication of how frequent they are. Auditory and visual hallucinations are the most common. So hearing noises or voices that when there's no one there, or seeing things that no one else can see. But you can get tactile hallucinations, so feeling things that aren't there. They come up in things like alcohol withdrawal, the symptoms called formication. It's a sensation of insects crawling on the skin because of the symptoms of the withdrawal. Olfactory hallucinations, or smelling things that aren't really there, is pretty uncommon, but I have seen it occasionally. And gustatory or taste-based hallucinations are quite uncommon. And I've actually never seen anyone who has actual gustatory hallucinations, but they are theoretically possible, and they have been documented. So we're going to talk a little bit about delusions first, because I want to expand on that a little bit. So as I said, they're fixed false beliefs, and they're not the same as opinions or misinformation. So while as a Canadian, I might think that Americans believing they're the best country in the world is delusional, it's actually just an opinion. And while we might like to make fun of them for believing that when we know we're the best country in the world, this isn't a delusional belief. And it might actually even fall into that category of appropriate for the culture. If all Americans believe they're the best country in the world, it's not delusional because it's part of their culture. But it's also this different from misinformation. So there's a lot of misinformation right now about vaccines. People who believe that vaccines cause your blood to be magnetic or cause more death than COVID, they're not delusional about it. They're just victims of misinformation. They may be gullible, but they're not psychotic. So it's really important to identify where the actual belief is coming from, and that's that external source that we talked about a little bit earlier is a key feature as well. Then we often classify delusions by their themes. So most people, when they think of delusions, they think of persecutory or paranoid delusions, but there are lots of other categories. But persecutory are the typical, somebody's out to get me, somebody's trying to harm me, someone's stealing from me, and they're actually probably the most common. Grandiose delusions we see in things like mania, but it can happen in other illnesses. So these are believing that I have superpowers, believing that I am really the son of the King of England, or other delusions that make me into something that I'm not in a grandiose or exciting way. Jealous delusions, we see that sometimes in dementia with delusions of infidelity, but it's usually about other people that are close to us, and we believe they're cheating on us. They're somehow doing things in the relationship that are inappropriate. Somatic refers to the body, so they're delusions about the body. So things like I'm rotting inside, or I have a cancer, it's incurable, I have some terrible disease and no one can figure it out. These are the types of things that we see in somatic delusions. And then erotomanic are sort of like the opposite of jealous delusions, where instead of we're believing that someone else, like the doctor, is in love with me, or the staff members of the home want to have sex, or they're trying to have sex with me. Of course, you can hear in some of those descriptions that some of these are going to be very distressing to the person, and some of them are going to be not so distressing. The grandiose delusions tend to be pretty welcomed by the person, even though they're just as indicative of illness. And of course, we have mixed delusions where you can have different parts of themes all incorporated into single delusions. Sometimes we'll see differences in the delusions because of the underlying cause. So the really common one that we deal with in geriatric psychiatry is dementia-related delusions, where it's more about the poor cognition and poor understanding of the environment. So the classic is the person who thinks that everything's being stolen from them. So I can't find my glasses. Someone must have stolen them. Because they stole them, once I find them, I better hide them. But then I forget where I hid them, so someone must have stolen them. And you get this circular problem that's really more about the lack of information and trying to make sense of partial information rather than it being something internal that's coming de novo. Medical causes like delirium or withdrawal from substances can often result in fluctuating delusions. So one day they think one thing, so the next day it might be something completely different. And so it can be really hard to keep track of. And then one of the things that's really key in primary psychotic disorders is that often the delusions are what we call bizarre or strange. So there are things that can't actually happen in the real world. Like I've been abducted by aliens and they examined me and then they sent me back home and I have superpowers because of it. It's not the same thing as someone stealing things. That could actually happen. Whereas most of the time, a lot of times in primary psychosis, the delusions are so bizarre that there's no question about could it really be happening. So we'll stop on delusions there and I'll do a little poll question about possible delusions. So Dr. Thomas is at home on a rampage because he can't find his glasses. He's accusing his wife of having, pop-up window. He's putting them away somewhere and essentially stealing them because she's always compulsively cleaning up. So am I suffering from a delusion? I'll give everybody a moment to. I feel like that little host and panelist cannot vote as taunting me. Maybe I can turn it off. Okay. I also feel like I have to fill the space while everyone's.
Yeah. Can you play like the trumpet with your hand or anything?
I wonder. Maybe I could do cats purring on my white noise.
Yeah.
And there is a question in the chat, but you may be going to address that later in your talk.
Well, why don't we go for it and we'll see.
So the question was about when you have a resident who's having a delusion, do you correct them? Do you just kind of go along with the delusion? How do you respond?
Yeah, that's an excellent question. And we're going to talk about that. So we'll get to that. All right. So basically all three of the answers could be right. So in reality, no, it's not a delusion because I do actually always blame her when I can't find something because she does compulsively clean and put things away. And sometimes I am red-faced and apologize because I actually then discover them where I put them and it's not fair. But it could be a delusion if I find them in my briefcase and yet I still think she must have done it on purpose to upset me and you can't convince me otherwise. Well, the last one probably isn't so true because she probably, even if I am delusional, she probably shouldn't have me heavily sedated. But depending, I guess, how you interpret the word rampage, that might actually be a reasonable approach because sometimes if things are out of control, sedation is the first option to make sure everyone's safe. So I keep forgetting that. There we go. Okay, so we're going to move on to hallucinations. So as I said before, this can happen in any sense, but some of them are much more common, and the auditory hallucinations and visual hallucinations are much more common. It's not too uncommon to run into the tactile hallucinations. As I said, it can be a symptom of alcohol withdrawal, delirium, other deliriums. And I've seen olfactory hallucinations in the context of very specific delusions where people believe that something is happening, such as people are pumping poison gas into my room. And so then they have an olfactory hallucination smelling the gas. But I've never seen olfactory hallucinations just all on their own without anything else guiding them. And as I said before, I've never seen anyone with gustatory hallucinations. Sometimes whether people have auditory hallucinations or visual hallucinations can give us a little bit of a clue as to what the underlying cause is. And I'm going to talk about that when I go through the different types. And the rarer types, the tactile, olfactory, gustatory ones, are often much more indicative of medical causes for the illness, whereas auditory and visual hallucinations are really common in primary psychiatric disorders and dementia. And so they can happen in medical illness, but if you see the other three, we're going to look a lot harder at medical illness because it's really uncommon for them to be present in a primary psychiatric disorder. And then one of the things we have to talk about is misperceptions and misidentification. So if you remember the baby doll that is being perceived as a real baby instead of an actual baby. So that's not actually a hallucination because there is a stimulus there. They're not experiencing this, seeing a baby when there's nothing there. They're misinterpreting the doll as a real baby. It's also possible for people to have illusions where they have an actual stimulus, but they perceive it as something else. So a good example might be someone seeing a pillow on the bed and thinking it's a cat or a dog or a baby, but they're seeing it as something completely different. We see this quite a bit in dementia. So a lot of times it's actually a misidentification. So it's not that they're actually seeing a cat, they just see something, they don't know what it is. And with their limited information they have, their brain tells them that it's a cat because that makes the most sense to them in the moment. So it can be a challenge, and it's important to know, is there an actual stimulus there that they're misperceiving, or are they seeing something completely out of the blue that's not there at all? And then there's the question of, is it really a hallucination? And we come across this a lot with dementia because people will talk about things as if they were there in recent memory, but they might be a memory intruding and they didn't actually see something. They're just misinterpreting the time frame in which they said things. And so that takes us to our next poll question of, is this a hallucination? So Mrs. Jones, being a 92-year-old lady with severe dementia, asks you during care, where did all the children go? So the question is she hallucinating? And so we'll give you a few minutes or a minute or so to look at the answers and figure out which one you think might be going on.
And while people are working on the poll, which I haven't seen come up yet, maybe it came up for the others.
Carl, do you have the poll there? Oh, there we go.
Should be.
There we go.
Yeah.
Someone was just wanting to make sure we clarified the abbreviations on the previous slide. And then we had a question about, what about people who seem to be particularly prone to believing in conspiracy theories? Some people seem to be susceptible, and is it possible that they have actually delusional or
That's a really good question, because there are people who tend to seem to be, I don't know if you want to call it more gullible or more prone to believe the bizarre. So there are personality types. So in extreme versions, it's personality disorder. So individuals with what we call a cluster A personality, schizotypal personality disorder is sort of the prototypical of that. They tend to have magical thinking. They tend to be more likely to believe unusual or odd things. They'll have strange rituals. They'll have they'll follow in new age alternative things that most people would consider crackery, and they do tend to be more vulnerable to that. And when we look at personality disorders, they are an extension of normal human behavior. And so it's easy to see the possibility that we, on one end of the spectrum, we have someone who has a true schizotypal personality disorder that impairs their function, somebody who's very concrete and not at all gullible and doesn't believe anything that anybody tells them. And maybe that's because they're a bit paranoid, but they don't fall for any of these things. And then there's going to be a spectrum in between. And so it is quite possible that there's people who are more vulnerable, but that's different from the true psychotic symptoms, where there's an internal rather than an external source for the incorrect information. But yeah, it's an interesting thought. All right, so do we have results on there we go. Good. So as everybody picked up from the previous slide, there's a pretty good chance that this is just an old memory, and that she's remembering something from years ago, but because of the difficulty understanding time, she thinks it was a few minutes ago. And this can be a real challenge for us, figuring out, is the person actually hallucinating versus are they just talking about things that happened a long time ago as if they were recent. But it's also possible that she did see children in the room. And a lot of times what we'll then do is come and talk to all the different people on the unit that we can find. And are there ever times where you see her and she says, oh, don't sit in that chair, there's somebody there? Or asking, well, what's that dog doing in here? Or what are those children playing with? Things that actually tell you that, yes, in this moment, she is seeing something that I can't see. That's really important to document, because that's really valuable to us. These things like, where did the children go, it's harder to interpret. It's still important to document it, and it's still important for us to know about it. But the real goal there is when you know that you're seeing the person actually seeing things that you can't see, and that's really helpful. All right, so we talked about symptoms versus disorders. So this is probably going to be pretty straightforward to everybody, but I want to just put it out there anyway to make sure. When we talk about psychotic symptoms, they're part of an illness. They're not necessarily the defining part of the illness. And you can have psychotic symptoms in things that are not necessarily psychiatric illnesses as well. So a good example is that delusion of theft. People are stealing things, I have to hide them, therefore I can't find them, therefore they're being stolen. That's a psychotic symptom, a delusional symptom of Alzheimer's disease or any other dementia. Seeing or feeling bugs is a psychotic symptom of alcohol withdrawal and some other medical illnesses. And then auditory hallucinations are a psychotic symptom of schizophrenia, which is a psychotic disorder. And so you have psychotic symptoms in psychotic disorders, of course. A psychotic disorder is the actual illness. It's the mental illness that has psychotic symptoms. So the classic one is schizophrenia, where patients have hallucinations or delusions, and they must have at least one of them. Most of them have both, but they're not the only symptoms of schizophrenia. People also have disorganized behavior and thought processes. They have negative symptoms like loss of social skills and social cognition that are not psychotic symptoms, even though they're part of a psychotic disorder. Delusional disorder is a really interesting one, where people have a very specific non-bizarre delusion. So there are things that could actually happen, like someone breaking into my house or someone stealing my flowers. But they only have that one delusion, and it's not a lot of different delusions. They're not bizarre, and they function really well outside of the stress that's caused by the delusion. And then mood disorders are primary psychiatric illnesses, but not all mood disorders are psychotic disorders. A psychotic depression or a major depression with psychosis is a psychotic disorder that often has delusions, sometimes hallucinations as well. So the big takeaway point is that psychotic symptoms don't necessarily mean you have a psychotic disorder, but if you have a psychotic disorder, you will definitely be experiencing psychotic symptoms. Hopefully that's clear. All right, so we're going to talk a little bit about causes. Now, there's lots of different causes of psychosis because these individual symptoms can crop up in a lot of different illnesses, but there are some that we more commonly see in the elderly. and some that are a little bit less common. Of course, the primary psychotic disorders are a major cause of psychotic symptoms. And we talked about mood disorders sometimes having psychotic symptoms, and not just depression, but also bipolar mania can be psychotic. It's pretty common to see it in dementia, although most of the time it's a memory-related symptom rather than the same type of cause you might see in schizophrenia, where it's about neurotransmitters in the brain. Delirium from lots of different medical causes very commonly has things like hallucinations, sometimes delusions, although, as I said, they can be really fluctuating and short-lived, and they'll come and go depending on the state of the delirium the person is in. There are specific medical illnesses that are known to have psychotic symptoms, in addition to just things like a delirium that could be caused by the underlying medical illness. And then certain vitamin deficiencies, substances, whether it's medications or substances of abuse, can also cause psychotic symptoms as well. So we're going to walk through some of these and get a little bit more information about them. So we're going to talk about schizophrenia first. So schizophrenia is one of those primary psychotic disorders. So they have, all individuals with schizophrenia have some psychotic symptoms, more often both hallucinations and delusions, although you do see patients who just have one. So someone who becomes delusional but never actually hears voices or experiences sensory symptoms that aren't things that aren't there. So schizophrenia is actually really common. So 1% of the general population, the prevalence is 1% of the general population. So about 1 in 100 people in Canada have schizophrenia or a schizophrenia spectrum disorder. Of course, if you go to a psychiatric hospital, you're going to see a lot more people with schizophrenia because they get hospitalized in psychiatric facilities. And it's actually pretty common in long-term care. So there's some studies, up to 12% of long-term care residents have schizophrenia. I think that number is probably a little bit high, but that may vary too, dependent on the underlying population that a particular home serves. So typical schizophrenia has onset in very early life, so late teens, early 20s, and it's a really devastating chronic illness. People lose function, they have difficulty developing their support systems and their early careers, and it tends to be a very chronic thing that they deal with. Now, while a lot of people struggle with it, there are lots of folks with schizophrenia who function really well. They have good supports already. They get into programs that are helpful for them. They take their medications and stick to it, and they can lead fairly normal lives. And others really struggle and constantly live in supportive housing and are in and out of hospital and really have a difficult life. So we don't really understand what the cause of schizophrenia is. There's probably a complex underlying set of causes, but the basic underlying abnormality is differences in how the brain handles and responds to transmitters like dopamine and serotonin. Dopamine is the most important one. That's the one that the medications target, but serotonin plays a pretty big role, and medications that target that can also be helpful. We talked about how different types of hallucinations can be part of different illnesses. So in schizophrenia, the most common hallucination is hearing voices. And it's actually pretty uncommon to have visual hallucinations or any of the other sensory modalities. And the voices, the auditory hallucinations in schizophrenia often have very specific features that we will ask about in trying to figure out, okay, are they just hearing noises or hearing voices because of a medical illness, or could this be schizophrenia? So in schizophrenia, the voices tend to be very external, so they'll hear them as a sound off to the side or behind them, but it's outside their head, whereas sometimes people describe hearing a voice inside their head when they're medically ill. The voices often make negative statements, derogatory statements. A lot of people will complain about how vulgar they are and how they're swearing. Command hallucinations are pretty typical or pretty specific to schizophrenia. So commands to do things like often negative, harmful things to hurt themselves, or telling them to go kill themselves, or that they shouldn't eat that because it's poison. So the delusions get worked into those hallucinations. One of the really interesting ones that is very specific to schizophrenia is the running commentary. So, for example, the voice, Carl might hear a voice saying, okay, well, Carl is drinking his coffee now, and now he's putting the cup down. He's getting up to go and put the cup in the sink. And it's like having a color commentator from a hockey game narrating exactly what you're doing as you do it. And it can be really distressing for people. The delusions in schizophrenia tend to be stable. They're often bizarre. So we talked about aliens and superpowers being surveilled by agencies like the FBI, CIA, when there's no reason that would happen. Other people affecting you somehow magically with technology. So beaming lasers into my head that is causing my knee to hurt, or controlling my thoughts with their telephone, or the TV speaking to me and telling me information that's specifically for me. So these are the types of things that we see in the delusions, and they're a little bit more distinct in schizophrenia than the general types of things we see in medical illness.
We have a few questions.
Sure,
so let me know when
that.
you're open.
Yeah.
Okay, so one question about you had schizophrenia as both sort of a symptom as well as a psychosis. So are they the same? Is there a distinction between those two things?
Yeah. So in that, I'll just back up here. This is the slide. So yes, so in the first chunk there, the auditory hallucinations themselves are the psychotic symptom in the schizophrenia. The schizophrenia is the psychotic disorder, and that's the point I was trying to make with that third line. And then with the psychotic disorder, that's the schizophrenia, and people with schizophrenia must have either hallucinations or delusions, the psychotic symptom. So the symptom is like the thing that you feel or the thing that you notice, and the disorder is the underlying cause. And it's a helpful thing to distinguish. It's sort of like, I'm trying to think of a good example. So if someone has a cough and a runny nose, right now we'd all worry that they might have COVID because they have symptoms of COVID with the cough and runny nose, but it might also be symptoms of a common cold, which is much less worrisome and scary. And so you've got two different disorders, the COVID or the common cold, that can share symptoms, and it's important to distinguish between what's a symptom and what's the disorder. That was the point there.
Someone else had the question about it sort of describes an occasional symptom that they have if they're very stressed about, like, say, hearing a phone ring or things like that. And is it common for people who don't have a underlying psychotic illness to occasionally have something like that happen?
Yeah, it does happen.
My pager, when I was in training, I was always hearing my pager going off.
Yes, and I always turn the sound off on my phone, but I constantly think that my phone on my hip is buzzed during the day, and it's mostly about the distraction, the stress, the expectation that something's going to call, and what they're describing with the phone ringing. That's actually really common for that to happen. And if we paid attention and got worried about these sorts of things, we might really freak ourselves out thinking that, oh my God, I'm going crazy because these little things happen. Part of it is probably because our brains are such complex things, complex mechanisms, that when we talk about these symptoms, they're part of normal human experience that gets out of control rather than being something completely strange and outside of our experience. So dreaming is an excellent example. When you think of dreaming, it's kind of like having hallucinations, but you're asleep. It's a normal part of the process, and some people will actually wake up and their dreams will continue, and so they're essentially hallucinating while they're waking up, but it's part of the dream mechanism not working quite right. And so there's lots of people who have little symptoms that could be psychotic symptoms, but they're just one-off things that happen when they're stressed, when they're tired, when they're had a little bit to drink. There's lots of different little causes there. And I just noticed the question about Lewy body dementia, and that's a really good one. And Lewy body can be mistaken for schizophrenia, and it's one of those things that where when we talk about the differences in the typical presentations, because Lewy body is typically a visual hallucination, which is a little less common in schizophrenia, but not impossible. But in Lewy body dementia, it's almost exclusively visual hallucinations, and they don't tend to have auditory hallucinations, whereas schizophrenia very commonly has auditory hallucinations. So that helps us differentiate it, but there's a lot more to it than that, and it is possible for things to be mistaken, schizophrenia mistaken for Lewy body and vice versa. I've seen people with sleep disorders who are diagnosed with schizophrenia because they have narcolepsy and they wake up and their dreams don't turn off, and they see things because they're slipping in and out of sleep so easily and quickly that they think they're awake the whole time, but they're actually dreaming. So there are lots of things that overlap and can be mistaken for one another. Good, excellent questions. So where were we? There we are. No, next one. There. So I talked about how schizophrenia is very early onset in teens and late 20s, but there are two categorizations of late onset and very late onset, which occur either after 40 or 45 and 60 or 65, depending on which set of guidelines you read. But it's people who have later onset schizophrenia tend to have a very different presentation because they've already established themselves. They've developed their personality is developed fully. They've got good support systems. They've got a social network. They often have a career. They have families. And they don't tend to develop some of the more debilitating symptoms, but they can still get the hallucinations and the delusional beliefs. And this is where the question about Lewy body is an excellent one, because differentiating a very late onset of somebody who's in their 70s and now they're hearing voices that are saying terrible things to them and narrating what they're saying, you have to figure out, is this very late onset schizophrenia? Is it a dementia? Or is it a mood disorder where the person is so depressed that they're hearing voices that are saying mean things about them, and it's really about their depression? So they tend to be a little less impaired because they have this good function beforehand, but they're not less distressed by the symptoms. And so it's still really important type of thing to identify and to treat appropriately. And then you might see someone referred to as having schizoaffective disorder. Affective is a term we use for mood disorders. And essentially, schizoaffective disorder is a mixture of schizophrenia symptoms and mood disorder symptoms. So someone who has the delusions and hallucinations and the other impairing features of schizophrenia, but they also at the same time end up developing a severe depression and the two illnesses influence each other. Schizophreniform disorder and brief psychotic disorder aren't so important in the type of work we're talking about here today, because schizophreniform disorder, you can think of it as symptoms of schizophrenia, but they haven't been present for long enough for the person to really qualify for a diagnosis of schizophrenia. So that's less relevant in the elderly because they're not, having this young age onset with the prodromal symptoms that lead up to the schizophrenia diagnosis. And brief psychotic disorder is essentially symptoms of schizophrenia in a fairly short time frame, and then they resolve and the person returns to normal. In young people, when there's no medical cause or anything that can be identified, it gets called brief psychotic disorder. But in the elderly, especially in long-term care, it's much more likely that a short period of time with symptoms that look like schizophrenia is really something like an acute medical issue, like a bladder infection or a pneumonia, where it's affecting their mental faculties because of the actual illness. So we don't really talk much about brief psychotic disorder in seniors. I talked a little bit about delusional disorder earlier. It's a single non-bizarre delusion without any other things. So they will believe one specific thing, like someone is breaking into my bedroom or my garage and stealing my potted plants. often it by definition, the non-bizarre are things that could be happening. And so it can be a little hard to figure this out because maybe someone is stealing your potted plants. But that's where collateral information can tell you a lot about whether this is really happening or not. And they can sometimes have hallucinations, but they're usually directly in keeping with the delusion itself. So for example, I talked about earlier, if they think that someone's pumping poison into the room or they're putting it into the food, they might taste it in the food, or they might smell the poison that's being pumped in, and that would be either an olfactory or a gustatory hallucination, but it's directly related to the delusion itself. And people with delusional disorder are actually really very functional otherwise, unless they have something else that's impairing their function. And there's probably quite a few of them out in the community who their delusions just aren't distressing enough, or they don't impact other people well enough to come to the attention of anyone who would otherwise want to treat it. So then we move on to, maybe I'll stop and see if are there any other questions about schizophrenia before we move on.
There was a question if there's a difference between schizoaffective disorders and like a depressive schizophrenia, if people have sort of read that term.
Yeah, I'm not sure what the term depressive schizophrenia refers to. I think it's probably talking about schizoaffective disorder. So schizoaffective disorder is people who have both symptoms of schizophrenia and symptoms of a mood disorder, usually depression, but it can also be bipolar disorder. And the set of symptoms happen together, but not exclusively together. So someone can have an episode where they have the ongoing symptoms of schizophrenia, and then they develop a mood disorder. They're low, they recover from the mood disorder, they still have the schizophrenia symptoms. Individuals with schizophrenia are very prone to depression. And so there are other criteria that help determine what's schizoaffective disorder and what is a person who has schizophrenia who then develops a depression because their life is not so good and they're really struggling. And I don't want to go in and get into the weeds on those very specifics, but I think that might be what you've read about when you think about depressive schizophrenia might be the same thing as schizoaffective disorder. All right, so when we talk about mood disorders, we're talking about two things: major depression and bipolar disorder, or the other way to think of them is unipolar disorder, which is just getting depressed, and bipolar disorder, which is sometimes getting depressed and sometimes getting manic. People with depression have to be really severe before they develop psychotic symptoms, but it does happen quite often, and especially in the elderly. The elderly seem to be a little bit more prone to depression with psychosis. When we see that, the delusions that they have tend to be pretty typically negativistic. So things that I'm a terrible person, I've done something terrible, everyone hates me. It's very negative towards the self. Somatic symptoms or hypochondriacal symptoms are very common. So I have some sort of illness, worrying about their health. There's a tumor inside and it's going to kill me. I'm going to die soon. And then these nihilistic delusions are the very negative ones, like I'm rotting inside, I'm going to die, I'm going to die in the poorhouse. Things they're really these very devastating beliefs that something really terrible is happening to them. So those are really typical. And when we see those, that's one of the first things it directs us towards this maybe as a depression, because you don't tend to see quite as much of this in some of the other causes. Hallucinations are a lot less common with major depression and psychosis. Sometimes people will have internal voices, and they're often the same self-recrimination: you're a terrible person, you're going to die. But we don't as often see people talking about hallucinations in depression. And then mania is the opposite of depression: someone who's too happy, who's agitated, who's going a mile a minute, their thoughts are racing, they're talking too fast, they bounce from activity to activity and topic to topic, and it's hard to keep up with them, and they don't really accomplish anything. We don't see that classic presentation in seniors quite as much. More often, the mania in seniors is more muted and more focused towards agitation, irritability, being easily angered, and so it can be a little bit more challenging to diagnose, because they're not running around and doing 3,000 projects and accomplishing nothing like a younger manic person might. But grandiose delusions are pretty frequent in mania, so things that make make you into a bigger person, a more important person, believing that you're the Queen of England or a relative of a queen, things like that. But you do see other types of delusions sometimes. And again, hallucinations are a little bit less common, but they do happen, and they tend to be along that grandiose type flavor to them as well. So that can sometimes give you a hint of what you're dealing with. It's actually the only slide I have on mood disorders, so I'm just going to pause and see if anybody had any questions about them. They're pretty straightforward.
There's nothing else in the chat right now.
Okay. Then dementia. So dementia is one of the things that we deal with the most, because so many people in long-term care have dementia or some cognitive impairment, even if it's not their primary reason for being in long-term care. And it's very common for patients with dementia to have psychotic symptoms. So studies estimate anywhere between 30 and 50% of Alzheimer's disease patients have some psychotic symptoms at any given time, and they can wax and wane. We tend to see delusions a little bit more commonly than hallucinations in some, with the exception of the Lewy body dementia that got mentioned earlier. And a lot of times it's partially because it's difficult to identify the hallucinations. Because of that reason, we talked about the difficulty telling the difference between a memory misinterpretation and a hallucination. And so sometimes you have to get lucky and just catch them in the middle of a hallucination to be able to identify it. The other complicating fact is a lot of these folks can't communicate to you. So if you ask them if they're hearing voices, well, if they're not hearing voices in that moment, they might not remember that sometimes they hear a voice in the room when no one's there, or they might not know what it means or be able to interpret it in the way that you're asking the question. And so it can be a little bit harder to get that history unless you observe it yourself. A lot of the delusions tend to be memory-related experiences. So it's the damaged brain trying to make sense of incomplete information. So delusions of theft we talked about. Misidentification syndrome is another really common one, where they mix up different family members in different generations. And so the old man in the room must be my father because I'm too young for that to be my husband. Or my son gets mixed up with my brother. I think that this older man that I remember must be my brother because he's too old to be my son. So we get misidentification syndrome. And then delusions of infidelity are also really common, because one of the key things that gets lost in a lot of the dementias is a sense of time. And so if I'm at home and my wife goes out to the store, and she's gone for what feels like 8 hours. Well, it doesn't take that long to go to the store, so she must be up to something else. And so maybe I start to believe that she's running around with someone else, because what other explanation could there be? Because my brain isn't functioning well enough to be able to come up with other explanations, or to just ask and understand the explanation that it's not actually 8 hours, it was only 20 minutes. And sometimes there's more mundane explanations. So one of the ones we run into a lot is people who complain about the old woman in their bathroom, or the old man in their bathroom. And we'll get people referred for hallucinating because they're seeing an old woman in their bathroom. But what's happening is they're walking in and they're looking at the mirror and they're not understanding that that's them. And they don't remember being that old, so it can't be them. So there's an old woman on the other side of the wall. And that can even become a very extensive description and a whole series of delusions built up about why there's this entire apartment on the other side of the wall, and why I can see into it, and why this person is always there when I'm looking into it, and why she never answers my questions when I ask them. And so it can be really distressing for people. There's a very simple solution, which is cover up the mirror with wrapping paper or a blanket, and that often solves the entire problem, depending on how impaired they are. So, I see there's something in the chat. Is that a dementia question? Oh yeah.
It's someone who has bipolar disorder, but then develops a dementia as a vascular dementia. And how do you differentiate between the bipolar and the late stages of the dementia?
Yeah, that's a really good question, because people with primary mental illness, like a bipolar disorder or recurrent depressions or schizophrenia, can also develop the dementia. And it modifies the mental illness modifies the cognitive illness and vice versa. And bipolar disorder can be a really hard one, because as I just said, and what I think Becky's probably thinking was, well, he said bipolar disorder in older patients often looks like irritability and agitation and easy frustration, which is what happens in patients with dementia. And it can be a really challenging thing to identify. And a lot of times it's about looking at their history. How do they usually present? Are there other explanations? Are there other symptoms that might suggest the bipolar disorder? So, for example, while this great big levels of activity and doing 1,001 things doesn't tend to happen in older patients, the talkativeness and the flight of ideas. So I describe flight of ideas as their thoughts are like trying to like drink from a garden hose. So you've got this sense of pressure behind them. They've got 1,001 thoughts going and going and going, and they're trying to get it out through that little hole that's their mouth. And you can see them jumping from topic to topic, and they're going from one idea to the next idea, and they're skipping a whole bunch of steps. Now, a lot of that stuff can also happen in dementia. And so Becky's quite right in asking about that, because it's really a challenge. And a lot of times it's about observation, getting as much good information as we can from all the people who know them, because that's one of the key things, is that all the frontline workers often know these people really, really well and can tell us a lot of information about what's different. And that can give us clues as to what to target, and whether we can actually use bipolar medications, or whether we're using the things we would normally use in dementia to try to manage these symptoms. And sometimes it comes down to trial and error. We think that someone has a major depression, but we're not sure, is it a depression or is it just symptoms of the Alzheimer's disease? We'll try to treat the depression, and if it improves things, then we assume it must have been a depression, and we'll keep an eye out for similar things. Same thing happens with bipolar disorder. If they're on a mood stabilizer and things are a little bit off, they haven't been taking it, or it was stopped recently, we put it back in, or we adjust it in hopes that that'll solve the symptoms. And sometimes it works, and sometimes it's really about the dementia progressing, and it's not about the mood disorder. So you can see where it gets quite complicated sometimes. Good. All right, so we'll move on to delirium. So this is really common in long-term care. Elderly patients are themselves more vulnerable to delirium because of the physical changes they have, and the changes in the barrier between our brains and the blood and the rest of the body. So things can cross over into the brain a lot more easily and cause more complications. They tend to clear medications less easily, so they're more prone to delirium from that. And they're much more vulnerable to medical illnesses, an illness that most of us might not even know we had, like a bladder infection. We might not even know we have, other than going to the bathroom a little bit more often, can make an 80-year-old lady with a vulnerable brain very, very delirious. So in delirium, what we typically see is the visual hallucinations. So things like picking at the air, trying to pick things up from the floor. We're often seeing bugs crawling on things. They can experience other senses, and sometimes that might give you a clue as to what the underlying cause of the delirium are, but most of the time these are such fluctuating symptoms that it's hard to say, oh, well, they're smelling this smell, it must be cause X. It's not that simple. The delusions come and go. They're often not as fixed and as persistent, but they can be very fixed in the moment. So often things that are related to the confusion, their poor understanding. So people are trying to hurt, people are beating me. It can be hard to interpret it sometimes, because it may be that they're talking about being restrained because they were so confused and out of control, and they remember that as being assaulted by staff, but it's them not understanding and not having the complete information about, okay, well, I was I was really out of sorts. I was doing all kinds of crazy stuff. That's why they strapped me down to the chair. So it may or may not truly be a delusion. It may just be a misinterpretation of what actually happened. Sometimes these delusions can persist even after the delirium cleared. And so that thing about being restrained or believing that people were trying to hurt them can often persist even once the person has returned to normal. And that's often just because of the difficulties understanding and sorting out those memories. And those, because they're more related to the poor understanding and the confusion and the memory lapse that was present during the delirium, it's often not something that we can treat other than reassuring them and helping them to move on now that they're feeling better. I'm going to take a minute because delirium is one of those things that we can do an entire talk on, because it's really a really important thing for staff in long-term care and physicians and nursing in hospital situations to understand. But I'm just going to talk about the core features of delirium briefly. So delirium is an acute onset problem. So the dementia, people often mix up delirium and dementia because they're both cognitive issues, but dementia comes on slowly over time, with the possible exception of someone having a great big stroke and then having cognitive impairment afterwards. But delirium tends to have an acute onset. So we're talking about days, maybe weeks of change, whereas dementia is months and years of change. But delirium also fluctuates, where dementia tends to be pretty steady with little ups and downs during the course of a given day or week. Delirium can fluctuate a lot. And so you can have periods of time when someone's very, very confused, and a few hours later, they might be much more themselves and much sharper. And then a couple hours after that, they might be very confused again. And so there's this up and down, very unpredictable course. One of the key features is inattention, or inability to focus. And so you'll find them very easily distracted. They're looking at other things. They're trying to hold a brief conversation, and any kind of noise nearby or someone walking by completely distracts them. And they often have disorganized thinking, so they can't get their thoughts together. They can't express what they're wanting. They get derailed, or they block their thoughts and they stop talking and lose complete track of what they're talking about. It's also very common to see an altered level of consciousness, so more drowsy than usual. Sometimes they can be hyper alert. Sometimes they'll be completely sleepy, or they'll be waxing and waning and coming in and out of alertness states. So these are the core features of the delirium, and in amongst that, you get the psychotic symptoms like the hallucinations or the confusion that leads to the delusional beliefs. So we have a question there.
Questions about treatment, which I don't know if you're going to talk about.
Yeah, we're going to talk about treatment. We're almost through the causes here. I'm going to try to speed it up so that we don't run over. I promised Carl I wouldn't, and I think I'm going to lie. So some of the other illnesses, Parkinson's disease is actually really common to see psychotic symptoms. So visual hallucinations, just like in Lewy body dementia, and delusions can happen both due to the illness and also from the medications. So when we talk about treatment, it's an abnormality in the dopamine response. So the production in Parkinson's disease, there's not enough dopamine production because the center in the brain that produces it is being damaged. We replace it by giving people more dopamine, but more dopamine can increase the likelihood of having delusions or visual hallucinations. There's a lot of neurological illnesses that can result in often hallucinations, but delusions do occur as well. Endocrine abnormalities, secondary effects of cancer. Sometimes if the cancer is in the brain and pressing on the wrong part of the brain, you can get psychotic symptoms. Sometimes it's because the cancer is producing hormones or producing other substances that then cause the symptoms. And then there's this really interesting phenomenon known as the sensory deprivation syndrome. So Charles-Bonnet syndrome occurs when people are mostly blind or completely blind, and their occipital lobe, the place that processes the visual information from the eyes, essentially gets bored because it doesn't have enough stimulation. So it starts to generate its own stimulation. So people will see things And they often know they're not real, but they can be really fearful and think they're going crazy because they're seeing tigers walking around the backyard, or a bear walking through their living room, or a person standing on their head and bouncing around the room. And they know it can't be real, but they don't realize that it's just their brain pulling something out, often pulling out an old memory, or pulling out something that it's just making up on the spot in order to keep itself stimulated. The same thing happens with musical ear syndrome. When someone's deaf, they may hear voices or hear noises. It's usually not as very specific and identifiable as a voice. It's more mumbling or humming noises, but they can have fully formed auditory hallucinations. And it's an interesting thing to explore in anyone who has those sensory deprivation, to make sure you're not throwing medications at them for something that's not going to respond. The deficiencies, we see these pretty rarely, usually in very specific situations. So B12 deficiency is pretty rare with a normal diet. Vegans and vegetarians are a little bit at risk for it, but it's usually caused by someone who has a dementia, is trying to manage at home, trying to manage and not having a normal diet. So they have the tea and toast diet, or they have an absorption problem. Sometimes our gut stops absorbing B12 efficiently, and it's easy to get around that with injections. B1 or thiamine deficiency often is related to chronic alcohol use, although there are other causes. And niacin or B3 deficiency can be related to alcohol, but also just some eating disorders as well as other causes. Elevated calcium levels or deficiencies in calcium can result in psychotic symptoms. And dehydration is another fairly common cause in community living elderly with dementia, because they're not drinking enough and they become dehydrated, or they develop a vomiting or diarrhea and they become dehydrated. Most of these deficiencies present as a delirium-like picture. So you get that fluctuation, you get the visual hallucinations and the variable delusions. And then medications or substances can be culprits. So narcotic pain medications and anticholinergic agents like Gravol, or I think another common one that you guys would come across, Benadryl, is another one that's commonly anticholinergic and can cause these sorts of symptoms. The anti-Parkinsonian medications we talked about, and they can be a cause. And then both intoxication and withdrawal from alcohol can result in usually hallucinations, and that's where we get those tactile hallucinations. And then cannabinoids or marijuana-derived products can result in increased paranoia and hallucinations, although it's probably more likely the THC component and not the CBD component. And we're getting more information about them and understanding them a bit better and how we might be able to use them. So that's, and then stimulant medications can cause a mania-like presentation, which can have psychotic symptoms. So I breezed through that really quickly because I want to get on to the treatment and approaches, because that's probably the most helpful one. But we're going to do another quick little poll. And so we're going to ask you what the likely cause, based on all that stuff that we just went through. So a resident you know and has worked with for many years and like working with and get along with well is suddenly really angry at you for stealing items from her room, including an old picture, favorite flapper dress, and her upper denture. She tells other staff that you've never been nice to her, and you've hurt her in the past. So what do you think is the most likely underlying cause for this change in presentation? Basically, what's the problem here?
All right, looks like we're still getting quite a bit coming through here, so we'll give it another 15, 20 seconds or so.
I wonder if I do my poor interpretation of the Jeopardy theme song, if that would violate copyright.
Yeah, you'd have to be pretty spot on with it to it'd be interesting. I guess it'd theoretically be possible to do it too accurately, though.
I suppose. I don't know if the criteria is it recognizable, or
yeah,
because if you're off key and you're out of tune, you're really violating copyright.
All right, I'll share the results here.
Okay, so, well, I have to say I am really pleased that most people picked the delirium with an unknown cause, because one of the things that's really, really important here is that it's a sudden change, and it could be paranoia due to dementia-related misinterpretations, and in fact that it fits pretty well, and it may just be that she's suddenly noticed that the dentures and the picture are gone, and has somehow landed on you, which I think would actually be the better outcome than a delirium, because the delirium is a life-threatening thing. The pain medication started last week is another good culprit, and it's kind of a delirium in itself. It's possible that it's major depression, because the anger and the negativity could be depression, and now it's becoming more obvious. And the late onset schizophrenia is not outside the realm of possibilities. I'm worried about the one person who would steal this poor lady's picture, flapper dress, and dentures to be part of a play. But I think everyone gets their props from different places. So I'm glad someone found that amusing enough to select. But yeah, so like I said, all of these things are a good possibility, and one of the first things you want to do is look at the delirium and make sure that you're not missing some sort of really important medical intervention. So we're going to talk first about non-pharmacological, and that I don't have a lot of slides on this, but we might spend a little bit of time talking about it, and the poll question coming up, I'm hoping it will generate a lot of talking from me, and we don't have as much chance to interact directly. So really important things when you're managing psychosis, whether it's caused by a dementia, delirium, a primary psychotic disorder, is you want the patient to feel safe and to keep calm, because an agitated, upset environment is going to agitate and upset the patient. You really need clear assessment. So we talked about some of those challenges about where did the children go versus are you actually are you seeing her seeing things in the room? Orienting the patient is really important. It can be very valuable. You lived here for a few years. You're in Pembroke, you're safe. Your family's coming in to see you soon. Things that are reassuring and help them understand the environment that they're in. And then validation of distress. And someone asked earlier, do you agree with them and go along with them, or do you not? And this is a tough topic, because arguing with them isn't going to get you very far. And you're probably going to upset them, and you have a pretty good chance of upsetting yourself. And both of you being upset doesn't do anybody any good. But you don't want to be playing into the symptoms and agreeing with them and potentially exacerbating them by making them think that, okay, well, Becky thinks that they've stolen my dentures. Maybe other people know that my dentures have been stolen, but you can validate their distress. So someone who is really upset because they think they're being stalked and following, saying, that sounds really scary. How about if I go and see what I can find out and make sure that you're safe? Or I'm pretty sure you're safe here, but I can see that you're worried. I'm going to go and see what I can do to help. Or distracting them to another topic and asking them about the picture on their bed frame. Or I think your daughter came to visit yesterday. Did you have a nice visit? That can sometimes be helpful. Depending on the situation, you're going to have a different reaction depending on what you know about the patient themselves or the resident themselves, and what works for them and what they don't like. So we'll talk about an actual example. So residents crying when you enter the room tells you that the woman next door is using a device to send radio waves into his brain and causes headaches and sparkling lights. So you can check any of the responses that you think might be helpful in helping this gentleman with his radio wave problem.
Okay, it looks like just over half of people have answered, but we're still getting some more coming in. So
see, there's something in the... Yeah, I see in the chat, someone's asking about a resident who's very paranoid and the staff are trying to harm her. And it is a really difficult situation because it can be all consuming for the person and they have a difficult time trusting or feeling safe. Sometimes if you're lucky and you have some members of the team that they feel more comfortable with, that they trust, that person can help to redirect or do the primary care. A lot of times when it's that serious, that's the point where we start to look at medications, because if there's no non-pharmacological ways that are actually helping the person feel better and to deal with their fear, then we do have to try to help reduce their agitation, their paranoia and their distress with medications. That's where the behavioral support service can be really helpful too, because trying to identify what triggers it, what makes it worse, who has less difficulties with the paranoia when they try to do care, can all be really helpful interventions that can just diffuse it and help people feel like they can provide the care safely. Because as you point out, it's really distressing for staff, not just for the patient themselves. So do we have, there we go. All right. So again, I'm pleased that people are enjoying the tinfoil cap and the Search the Neighbors radio wave. I like to imagine that it's the same person who would both search and confiscate and make him a cap. But other than the first question, the first answer and the last answer, all of these could in certain situations be a reasonable approach, because if asking him if there's anything you can do to help him feel better, the answer might be kick her out of here or go destroy the transmitter, which is obviously isn't going to be very helpful, but you may get some insight into something else that's bothering him and needing something for the headaches, or maybe he's having a migraine and this is like his old migraines, and you might trigger him telling you that this is like the migraines and here's what used to help. Not very many people pick the radio waves don't work like that and that he's fine, and I think it's a good impulse. There may be certain people where being really direct and saying that that's not how radio waves work might be a good approach. Telling him he's fine when he's clearly having headaches and seeing sparkly lights probably isn't going to work very well, though. So if that answer was worded a little differently, I think more people probably would have been comfortable doing that. I think something like that isn't possible, and you'll ask the doctor if there might be another reason, might be helpful. You might get some backlash, because if you directly challenge a delusion, you can sometimes get a negative response. But sometimes it'll result in them thinking, well, okay, maybe if the nurse isn't, or the PSW is not too worried about it, maybe I don't need to be worried about it. I can see if there's another reason. The second last one, reassuring him that he's safe and that you'll check and make sure nothing bad is happening, is a really good approach, and that can work really well. Although sometimes it will backfire. And so one of the things you probably noticed in my poll questions is there's a lot of right answers and even some ways that the seemingly wrong answers might apply. So when you're focused on the resident, their distress, and validating it and trying to help them, that's a really good starting point. Now, obviously, when things are being caused by an underlying medical issue, you want to make sure that you're treating it. So antibiotics for infections, supplements for deficiencies, trying to minimize medications, get rid of problem medications, reducing substance use. If someone has a regular glass of wine ordered twice a day, maybe it can be reduced a little bit. Maybe that will help. It may not be the cause. And optimizing treatment of their underlying illnesses can be really important. And then there's antipsychotic medications. So we use these agents to block the dopamine receptors. And you remember we talked about how dopamine is a large part of schizophrenia. It's also a large part of some other sources of delusions and hallucinations. The newer agents also affect serotonin and some of the other receptors, so they can be beneficial. But one of the important things to know is that these are potent medications that carry risks. They have higher all-cause mortality. They increase the risk of stroke. They increase the risk of falls. They often cause sedation. They can cause Parkinson's symptoms themselves, which can then decrease mobility. The falls and breaking a hip, of course, is going to decrease mobility. So one of the main things that we always are asking when we're talking about, okay, this person has psychotic symptoms, the non-pharmacological efforts that people have made aren't helping. They're really distressed. What can we do? Are they likely to respond to blocking those dopamine receptors with an antipsychotic medication? So I'm going to walk through, just to give you a quick idea with the different disorders, what we might say in answer to, do we use dopamine blockade? And in a primary psychotic disorder, like a schizophrenia or any of those related illnesses, the answer is usually going to be yes. The antipsychotic medications are the first line treatment for schizophrenia at any age. Even if someone's 85 and they have a very late onset schizophrenia, we're still going to target it with an antipsychotic. We're going to be careful. We're going to start at a low dose. We're going to go slowly, but we still need to treat it. And the side effects that happen often have to be balanced against quality of life and the amount of distress the symptoms cause. In patients that are cognitively intact, I've had people who will tolerate some pretty nasty side effects if it makes the terrible voices go away. And even had a fellow who had to wear a bib because he was drooling so badly from the antipsychotic, who said, I don't want to lower the dose because the voices are going to come back. And he would tolerate drooling nonstop in order to not have to listen to voices telling him that he needed to kill himself or kill his friends and family. Usually people with primary psychotic disorders need lifelong treatment, so they're going to be on these medications for a long time. When it's a mood disorder, so a psychotic disorder with depression with psychosis, or a bipolar disorder, mania, the answer is maybe, probably we're going to use an antipsychotic, especially in depression. First line treatment for depression is antidepressants, but often psychotic depression and mania itself need more, and antipsychotics are one of the first line medications. There are other things that also treat mania that we use that we don't generally use for psychotic symptoms. But we're usually talking about moderate length treatment for 6 or 9 months, and then we try to get them off of the medications because they don't need it long term. They can remain on their mood medications, either the mood stabilizer or the antidepressant. In dementia, the answer is often maybe. We talked about how a lot of these delusions are memory related and they're not actually driven by dopamine. So giving them a dopamine blocker isn't going to help the lady who thinks that you've stolen her upper denture because she can't find it, because that's not a dopamine process. If she's really, really distressed and agitated, we might end up treating with an antipsychotic because it's going to lower that distress, lower that agitation. They'll be less worried about the things that they think are going on, but we may not be directly treating the delusion itself. Hallucinations in dementia tend to be a little bit more, probably more towards a probably answer, because unless they're very non-distressing, we tend to get more results out of the dopamine blocking medications. That said, because of these risks, if the person is completely not distressed and they see a bear walk across their living room and they don't care, we're not going to put them on a medication just to get rid of the bear if it's not causing any problems, because the risks probably outweigh the benefits. In delirium, the answer is often probably. They're not really useful in treating the underlying cause. You need to fix the underlying problem, but they often get used short-term for agitation. But you have to be really careful, because sometimes the side effects of the medicines can make the delirium itself worse, and that often guides which specific agents we use. But it's still always a concern, and so utilizing the lowest possible dose for the shortest period of time is often the approach. Oops, the wrong way. In Parkinson's disease, the answer is going to be maybe, because antipsychotics dopamine blockade is the direct opposite of the Parkinson's medicines. They'll worsen motor function, and they tend to respond to and tolerate only very low doses. So again, that's that question of, are the symptoms actually distressing? Do we have to treat them? And the same thing happens with Lewy body, although the answer becomes probably not, because these patients often have really bad reactions to antipsychotics. They are often less distressed by the hallucinations, although it still can be a problem. And sometimes you still need it because of the level of distress they have and the behaviors that they develop. But then in those cases, we're using extremely low doses, very slow increases, and watching them really carefully, because we don't want them to have these very bad reactions to the antipsychotics. In other illnesses, the answer is going to be maybe, depending on the underlying medical illness. They might be used short-term for distress and agitation, but usually the primary intervention is optimizing of their illness or the underlying cause. And then with the deficiencies in the substances, the answer is usually probably not, because the symptoms will resolve fairly quickly with correction of the deficiency, or with resolution of the withdrawal, and you're supporting their system through the withdrawal process, or coming off of the substance if it's an intoxication process. But there might be a role for short-term treatment of distress or behavioral challenges. If someone's really wild because they're intoxicated and out of control, then they might end up on a medication to do that, to manage that. And then we're going to finish off with one more poll about, is a medication needed? So, resident frequently reports that a snake is on the foot of her bed at night. Although the animal never moves, makes a sound, she's worried it might bite her one day. Is she going to need a medication? I'm just going to pop up the chat there and see. I see there's a few questions.
Questions about side effects from the medications, and then a little bit more about the receptor mechanisms.
Okay, let me just go back. Here we go. Yes, so interesting question about my fellow with the drooling. And yes, there are things we sometimes do that can help stop the drooling. So atropine drops and scopolamine are sometimes used locally under the tongue. I'm a lot more wary of that than I used to be, because I've had a couple of people who get floridly delirious from having this anticholinergic agent that when you put under the tongue, you would think it would just be local, but it can go systemic. And I've actually had a couple of people get very delirious on that. So I'm a lot more careful. With my particular gentleman I was describing, we actually tried that and it didn't help him at all. And he tried scopolamine as well, and it just made him feel awful. So he didn't want to keep doing that, even though it did help the drooling a little bit. And it was kind of a sad situation, because we never really got a solution for the drooling, other than the fact that he tolerated it because it made the terrible voices go away, and it was pretty sad. Interesting that block the dopamine receptors. So lack of dopamine in the problem is probably more too much dopamine, because we're blocking the receptor and preventing the dopamine from getting to the receptor and activating it. It's not quite so simple. In Parkinson's disease, it's a little more straightforward. The underlying problem is not enough dopamine in Parkinson's, and then you add in more dopamine so that you're providing enough of it that the receptors are properly stimulated. That's why when you give them the dopamine, they can develop the hallucinations or the delusions, because there's essentially too much dopamine for the amount of receptor. But it gets even more complicated than that, because our bodies, when we don't have enough of something, or when we're blocking the receptor, we just tend to make more of it to overcome the problem. So if you're blocking it with an antipsychotic, then our bodies just make more receptors, which then the medication will block. So then our bodies make more receptors. And so the answer isn't so simple as how much dopamine and too much dopamine, because it's all about whether they've been treated and whether they've upregulated receptors, whether they're downregulating receptors because there's not enough dopamine around, or you've removed the blockade. So yeah, it's a really interesting speculation, and you're sort of going down the right track. It's just that the reality and what happens in there is a lot more complicated than just the one molecule hitting the one receptor. And therefore an antipsychotic causing more harm, that is sometimes an issue. It's not usually directly because of the dopamine, but because of what I just said about the upregulating of receptors. Some of you may have seen people who have movements around their mouths, or they have these writhing movements of their hands or their bodies. And for some of them, that's tardive dyskinesia. It's a problem where those receptors get upregulated so much because they're being blocked by the antipsychotic that there's not enough antipsychotic medication to block it. An increase in the antipsychotic gives them different symptoms. So you have all of these receptors that are unblocked, and that suddenly causes all the muscles to move in an uncoordinated fashion that is sometimes distressing, sometimes not. And so that is the antipsychotic causing harm, because we've caused this upregulation, and just getting rid of the antipsychotic doesn't solve the problem, because then you're just opening up all of the receptors, including the ones that used to be blocked. And so this is one of the reasons we're really careful with antipsychotic medications, because they have long-term and short-term adverse outcomes. Someone who regularly refuses their medication affect their hallucinations and paranoia? Yeah, so absolutely. If someone with schizophrenia who is regularly refusing medications will probably have an increase in their number of symptoms and the intensity and the frequency of hallucinations, delusional thoughts. They can also develop motor symptoms. So that what I was just saying about the receptors being blocked, when you suddenly take away all that blockade, you've got all these greedy receptors there grabbing every piece of dopamine the body makes. And because there isn't enough dopamine to satisfy all the receptors, then you get these movements, and you can see people get agitated or restless or have these writhing movements because their receptors are unblocked. So that's very common in schizophrenia to see an increase in psychotic symptoms, but you'll also see it in someone who we might be using the antipsychotic for settling or treatment of agitation. If you take it away, of course, they're going to get more agitated if it works for them. So it's always this delicate balancing act of using the medication at the lowest dose you need, but still effective, and trying to use it for the shortest period of time, but not taking it away while they still need it. All right, so how do we do on our poll? Is medicated needed? So keeping in theme with my, nobody thought a mongoose would be a good idea. I don't know if you can get mongooses in Canada, but yeah, probably not going to put a mongoose in her room. And most people selected maybe if she is able to understand the snake isn't really there and accepting a reassurance, you might be able to get away without the extra medication. And that's really one of the best first steps. But if she is actually seeing a snake and she's hallucinating and it's really causing distress, then she may benefit from an antipsychotic. Part of it is going to depend on what's causing it. If she's completely blind and she's seeing the snake because of that Charles-Bonnet syndrome, where the part of her brain that receives the information from the eyes is bored and is making it up, then an antipsychotic is probably not going to do very much to her. The first no answer, the hallucination is not causing distress and she shouldn't get extra medication because it's risky, is a good answer, because if she accepts the reassurance like she did in the second last answer, then you're not putting her at extra risk. But you want to make sure you're understanding, is she really not distressed? Are we adequately reassuring her, and is she accepting it? And then the dopamine related symptom and medication is not helping. It really depends on the underlying cause, because the fact that it never moves, never makes a sound might be something like a Lewy body visual hallucination, or it might be that Charles-Bonnet syndrome that we talked about, and that's probably not going to respond as well to an antipsychotic. But reassurance being the only treatment might not be true either. So probably the best answer is the maybe, and we can avoid extra medication. But if she's not accepting the reassurance and it's distressing her, it may be worth trying. And that takes us to the end. And I don't get to see anybody on Zoom, which I find is very difficult. I play off the audience and their responses, so it's hard. But I've gotten used to it in 2 years. So hopefully you guys find that helpful and understand psychosis a little bit better. Sorry, it's scrolling up. Vicks smells like mongoose poop.
Huh.
So Ken's comment is really interesting, because some of these, so the hallucinations from Lewy body and the Charles-Bonnet syndrome hallucinations can actually respond to internal changes in the way you think of something. So it's not super common, but I've had a number of patients who they see the hallucinations, they know they're not real, and they just tell them to go away, and they do. And the hallucinations respond to the instructions. And an unconscious thing like Vicks will drive away snakes might actually work, because the hallucinations are generated internally. So they're going to respond to the internal milieu. And if she believes that your intervention is going to actually fix the problem, then it might actually fix the problem. And so it's not a completely wacky idea. You want to be careful though, because you don't want to be playing into it and making things more complicated for yourself. But reassuring her that you don't see a snake, that you don't think there's a snake there, and having another way of getting around it, like I'll come in, we'll have somebody come in and pat down your bed and make sure there's no snakes before you go to bed. That may help, because if she's reassured that there's no snake there, then she may not see it. And it's not actually a totally crazy idea. I don't think that would apply to the tin foil hat though, but maybe he wouldn't be worried about the headaches coming from the radio transmitter if you gave him a tin foil hat. Who knows? I think our respective colleges might be a little bit unsure about the
creative solutions.
Sometimes you got to think outside the box.
Yeah, absolutely. Well, thanks so much. And I see all the thank yous coming in the chat there. I hope you have a chance to have a look at that.
Well, that's great. I appreciate it. And it's always great to have an interested group that's happy to ask questions, because at least it gives me some interaction with everyone, which I've missed over the years with all the Zoom stuff we're doing with residents and outlying areas. I miss being able to joke with people and see their responses to it.
Yeah.
But that's why I appreciate the ones who pick the ridiculous
Yeah,
answers.
the mongoose.
At least gives me some sense that someone's getting the joke.
Well, it seems like there's a lot of people saying how much they learn from the talk, and I'm definitely one of those people. So, and I just I want to mention to before we sign off here, I just put the link to the post-session survey in the chat. So if you click on that, it'll bring you to SurveyMonkey, and you can fill that out there. If you don't have a chance to fill it out tonight, don't worry, I'll email it out to everyone within the next week. So you can fill it out either now, or you can fill it out next week when I